teaching nurses at the University of Minnesota School of Nursing. My clinical background is mostly in emergency department nursing, critical care, and I also did some public health nursing and then got involved with policy, politics, and law.
Great. Well, it looks like we have a number of nurses in our audience that are practicing in acute care settings, much like you, Anna. National Nurses Week is a time for celebration, recognition, and reflection. This year's National Nurses Week broadcast focuses on ethical decision-making and action. We celebrate the fact that the annual Gallup poll has listed nurses as the most trusted profession for the past 15 years. While it's an honor to be recognized as the most trusted profession, it comes with a cost. We're curious as to the number of ethical situations you've encountered in your practice over the past month. Again, you have a polling question, so please go ahead and answer it. Now, moving on, again, this is an opportunity for reflection and renewal in your practice, and we look forward to learning strategies that will help us be courageous leaders in these moral and ethical situations. So Cheryl, over to you.
Thank you so much, Terry. It is my pleasure to have the opportunity to speak about AACN's work in this important area. But first, let's see what we learned from our second polling question. So I looked to see, and it appears that most of you have had within the past month 0 to 3 situations, but we do see that there are other places where you have had experiences that can be as high as 10. So clearly this is a constant and ever-present issue for us that we need to deal with. AACN is pleased to be celebrating 2015 as the Year of Ethics, highlighting the revision of the Code of Ethics for Nurses with Interpretive Statements. Today's code has evolved from our first code for professional nurses approved in 1950. The 1950s code noted that service to mankind was the primary function of nurses and the reason for the existence of the nursing profession. It also noted that nursing service is universal and unrestricted by considerations of nationality, race, creed, or color. Much of what was held dear in the 1950s code still resonates in today's world. Values such as the commitment to care for all, to hold confidential patient information, concerns about conflict of interest, and the role of the nurse as a patient advocate are clearly present in the current code. The Code of Ethics for Nurses is an enduring document that is succinct statement of the ethical values, obligations, duties, and professional ideals of nurses individually and collectively. It is the profession's non-negotiable ethical standard that is applicable regardless of the venue of care or the role. And it is an expression of nursing's commitment to society. This document is an essential guide to nursing practice. With this current revision, the overarching provisions remain constant. However, the interpretive statements were updated to reflect on particular concerns of today related to the work environment. In particular, the nature of our relationship, not only with our patients, but also with each other and to other members of the team. In addition, the committee strengthened the language with regards to our role in addressing global issues, issues of injustice and inequity, and to advocate for policies that minimize the impact of the social determinants of health, such as education, housing, the physical environment, and poverty on society. The Year of Ethics and our National Nurses Week theme, Ethical Practice, Quality Care, provide us with a framework for linking clinical practice with who we are as ethical professionals. This webinar is about taking action. I hope that each of you will take the pledge to strive toward ethics as a critical part of everyday nursing practice. Johns Hopkins School of Nursing, this pledge is about taking action. Thank you for joining us today, and happy National Nurses Week. So now I turn it over to Anna, who is going to talk about today's case study.
Thank you, Cheryl, and thank you everyone for joining us today. Happy National Nurses Week. I am so excited that so many of us are interested in ethics and how ethical decision-making affects our patients and our practice. I am going to start the dialogue by first presenting a case study of the anuric patient. Please follow along with me. Patient Mr. Van is admitted to the Medical Progressive Care Unit with signs and symptoms of fatigue and lower back pain. Nancy Abadier, RN, is assigned to take care of the patient on his second day of hospitalization. During the 7 a.m. morning handoff report, she finds out that the patient has history of renal agenesis, single kidney, and his creatinine was elevated in the morning labs. During the 7 a.m. rounds, the medical team does not address the elevated creatinine, but they order additional lab tests to be performed in the afternoon. By 2 p.m., the patient has become anuric with no urine output for 8 hours, and when the afternoon labs come back, the BUN and creatinine are elevated from the baseline. Nancy pages the resident, Dr. Kim Meisner, with the results, but does not receive a callback until an hour later. Dr. Meisner states she will need to speak to the attending physician before writing orders. It is now the end of Nancy's shift, and the patient has no urine output. In addition, there are no new orders. During the 7 p.m. handoff report to the next shift, Nancy expresses concern about Mr. Van's condition and blames the lack of intervention on the medical team. As you are reading this case, you probably are wondering about a few of the facts. What are some additional facts that are needed to make a decision? Clinically, we can think of facts such as the vital signs. We are not given the information, but it is helpful to have vital signs for the patient as well as the volume status. Some questions I would ask to the night shift if I was the one taking report: how is it trending? How is the urine output trending the night before? As well as, was a bladder scan performed during any time of the shift? Some other laboratory values that will be helpful is complete blood count as well as urinalysis. Also, were other diagnostic tests performed on the patient? An ultrasound, a CT, that could give us helpful information. As you can see from the case, there are a couple of issues here. I'm actually going to turn it to Eileen so that she can help define some of the terminology that will be helpful in thinking about this case.
Thanks, Anna, and I want to thank AACN for having the wisdom to make this the year of ethics. And I think the size of our audience shows how true that rings and why the largest profession in healthcare is the most trusted profession anywhere. So just like nurses do every day in assessing problems and naming them, it helps to have a rubric of concepts that you can use in assessing this scenario and others. First of all, what's a problem? A problem is simply a discrepancy between the current state and the desired state. In a non-healthcare example, I would offer that I'm XX number of pounds overweight. That's the current state, not my desired state, so it's a problem. It's not an ethical problem. Secondly, we have dilemmas. Dilemmas are when you have two mutually exclusive, equally unsatisfactory choices, and one has to be taken. So again, outside of healthcare, you might think of a situation where a nurse may have, actually this is in healthcare, a nurse may have a patient who goes badly towards the end of a shift, so there's a crisis. The nurse's professional obligation is to stay with that patient till help can arrive, even though the patient, the nurse has to leave that a social obligation. This is actually an example of a practical dilemma. We also have ethical dilemmas where you have the two mutually exclusive, unsatisfactory choices where there's moral obligations involved. Nurses face these all the time when they're dealing with their duty to protect and preserve health and their duty to honor autonomy and to relieve suffering. So we have dilemmas that can be practical and ethical, and they can feel similarly to nurses because that emotional response may be the same. And then finally, we have moral distress. Nurses experience moral distress so much, it's almost like an endemic situation. Moral distress is when nurses know what to do, they know what their ethical duty is, and they know the right path to take, but external constraints keep them from taking that action.
Thank you, Eileen. The definitions are very helpful. I think we're ready to move to the next polling question. It's going to come up on your screen. Audience, please help us answer the question. The question says, what questions do you need to ask? And you could choose all that apply. We're getting some answers right now. You should see it on your screen as well. The first one, what is Nancy's level of fatigue?
Well, it's very important to include this in assessing what's going on because we do know that fatigue plays a big role in the risk of adverse events happening. So this is a 12-hour shift for Nancy, and we don't know how many 12-hour shifts in a row she may have had to work if this is an overtime, but we do know that the fatigue increases the risk of adverse events.
The second one says, is staffing adequate to allow for multiple phone calls and pages to the prescribers? This is such an important point. We know when we don't have enough staffing, patients suffer. In this case, we're not really given that information if the RN Nancy had support and if she had multiple patients, she had to run from one to the other and did not get the chance to page the physician again. But it is important to know that knowing the staffing levels and how the work environment functions, it supports the nurse and patient outcomes and the quality of care patients receive. Dr. Linda Aiken and her colleagues have demonstrated the important link between healthy work environment and patient outcomes. She has demonstrated in studies such as showing when one additional patient is added to the nursing workload, after a procedure, the risk of mortality increases by 7%, which is a lot. Also, hospitals that have staffing ratios for nurses that have 8 or more patients, the risk of mortality increases by 30%. This is an important research finding. Also, there is a positivity of the study. It shows that if we have enough staffing in hospitals, then patients are discharged home earlier and there's less complications, which saves the hospital and the unit a lot of money. I think it's important for supervisors to recognize this because when they're doing the staffing ratios, they can think about certain situations, complex care or ethical situations that could lead to staffing decisions.
Good point, Anna. And another choice here that many of our respondents have picked is what are the communication challenges that are present here. Communication can be a huge part of scenarios like this. In fact, some dilemmas that present as perhaps an ethical dilemma sometimes end up being just a communication issue. And nurses are working in environments that did not always promote maximum communication. You may be working with an electronic health record that facilitates or doesn't quite facilitate really great interprofessional communication. There may be misunderstandings of the facts that are going on. And many times nurses work in hierarchical structures and settings where there's a fear factor involved with completely open, transparent communication. There are tools such as the team steps and the concept of just culture that help the these practice settings that are overly hierarchical to promote the kind of open communication where situations can be readily assessed and addressed and where adverse events can actually be prevented.
I think they are all great points. What is the desired state is number D. That was a choice. And I think thinking about this case, we're worried about the patient having acute kidney injury. It's been 13 hours since he has actually urinated, and we know when the creatinine levels are going up and the patient is not voiding, he is at a high risk for losing his other kidney. So there's a big concern there. But going back to communication, the important part of the desired state is having open communication with your team members and having a plan of care for the patient, where it's communicated to the patient, to the family, to the nurse, and everyone else on the team, where everyone is aware what the diagnosis, the prognosis of that patient is going to look like, and we're all on the same page.
Right. So we see here that really the only incorrect answer is the last one that says, well, how long and how well does Nancy know Mr. Van? The fact is that her ethical obligation to Mr. Van begins the minute he is assigned to her. It doesn't matter how long or how well she knows him.
So I think it's time for us to look at another polling question. This question is, what kind of issue is presented in the case study? And you are to select the one best answer. And you'll see this D. The answers are the rubric of problem, ethical dilemma, practical dilemma, and moral distress.
Okay, it looks like we have a variety of responses here, and the one assessment of this issue is that it is probably a moral distress scenario. Remember, the moral distress is when you know what the correct thing to do is, but you're constrained from carrying it out. And we do know that Nancy did try to reach the medical team for the necessary orders and interventions. A case could be made that this is perhaps a practical dilemma, and that would be true if Nancy's motivations for acting the way she did were based on personal convenience, such as just wanting to get out or if she was lazy. But we really have no evidence of that, and so it's probably most accurate to consider the situation a moral distress situation. There's also a lot of overlap often between ethics and law. So I just want to take a second to address the legal implications here. Nancy does not only have a ethical obligation to her patient, she also has legal obligations in this case. Remember from your basic nursing education into negligence and malpractice that there are several components there. There's the duty that we have as professionals, and that's outlined by standards of care, many of which the American Nurses Association has outlined. Then there is, in an unfortunate situation, a breach of those duties. An error happens. That error then becomes the direct cause of harm to the patient. So when all of those are present, we have a situation that may end up being a negligence case. So it's important to keep those in mind. But I think what we really have here is a moral distress situation, and it calls on us to apply the Code of Ethics that ANA has revised this year. One of my favorite things about the Code of Ethics is how clear and unequivocal the language is, Anna, and how applicable it is across so many settings.
I think that's true. I think the Code of Ethics is so powerful and empowering for nurses. The first three provisions of the ANA Code of Ethics describes nurses' patient advocacy roles as providing compassionate and respectful care. It also talks about being the primary commitment to the patient and promoting patients' health, safety, and rights. Provision 1 says nurses should practice with compassion and respect towards every person. This is so important. I was actually interviewing a patient a few weeks ago from our patient advisory group, and when he told me when he initially got diagnosed with heart failure, they just gave him the diagnosis without any kind of compassion or care, and they left them to decide his fate. He lost all hope and was just waiting, he said, to die. Finally, a physician referred him to a center that understood his problems and they were able to treat him and put him on the road for transplant. He said what made the difference is when practitioners cared, when healthcare providers really came into the room and they were engaged with his history, they knew what was coming, and they cared, they showed care. So I think that's important. That provision one is really important. In this case with Nancy and our patient, we don't really know if Nancy is showing compassionate care. That's not really described here. But I think it's important to know that at the end of her shift, she's blaming the medical team. And that's not very compassionate. I think there needs to be improvement in that area with teamwork and collaboration. For provision 2, the nurse's primary commitment is to the patient. Advocating for Mr. Van, the patient, should be Nancy's priority. In this case, Nancy could have used a chain of command and paged the physician, the attending physician. I've been in a situation where the attending did call me back and said, "I'm sorry, I'm waiting for the specialist to call me back. We need to just wait until the specialist lets us know what to do." And I've said, is it fine if I page the specialist? So I've taken that extra step and followed through chain of command. We have so many resources on the unit, and I think knowing your resources and who you can go to when there's a problem like this is important. Collaboration teamwork is an important part of this provision, and it's our professional duty to collaborate. Provision 3 states promoting, advocating for, and protecting the rights, health, and safety of the patient. Nancy's duty is to make sure she promotes culture of safety on her unit. And if there is a place where she sees a gap, she can reach out to her leadership, and ask for additional support or direction. What about other provisions? I know we have a few others that are on this list. How does this apply to the case, Eileen?
The code is so smart in the way it's divided up. The first 3 provisions being about our direct responsibilities to patients. The second 3 provisions sort of taking it outside of the immediate practice setting. And the final 3 provisions really going to our obligations to society as a whole. So with provision 4, we're talking about the nurse's accountability, responsibility, and authority for nursing practice and the settings it takes place in. I know that nurses are very familiar with the idea of being held accountable for what goes on in practice settings. But I don't know that nurses always realize the authority that they have and that they bring to making changes when necessary. I can think of a nurse I knew from Minnesota who saw so many issues with injuries in the workplace. Her name was Betty Shogren, and she worked very, very hard to get safe patient handling instituted, and it is now the standard of care across the country. So there is also a nurse executive named Bernice Ferguson who ran the whole VA nursing system, tens of thousands of nurses, and she would keep a staff ICU nurse in her office so that she could run by that nurse her ideas for policy changes. So just think of the authority that that direct care nurse had in that situation. Nurses have, and they should use, the authority they have for nursing practice to make the changes that are necessary. Provision 5 really says we have a duty to respect and promote the health of our patients and all people, and that applies to ourselves as well. So Provision 5 talks about the nurse's duty to promote his or her own health, character, integrity, continuing competence, and all of that I think is very important in this case. Nancy needs to not only take the accountability and authority to improve what's going on, but to also maintain her own energy level, her own health. Again, when you think about fatigue issues. So in Provision 6, we are introduced to the idea of collective action, that nurses both individually and as a group should work together to promote the kind of moral practice settings that patients deserve. And so that is suggested by our question that we had on who would you bring into the scenario to help solve this problem. So that's a very important provision here. You don't do this alone. You should definitely think about who from your own work setting and from your interprofessional colleagues you need to bring into this situation. The code is very, again, the unequivocal language. It actually tells us in this provision, number 6, that if you try everything you can, individually and collectively, and your efforts are met, they fall on deaf ears, and there's no progress made, that you actually have a duty to resign from that situation and continue working on it from perhaps outside the setting. There's this idea that if you're not part of the solution, you're part of the problem. So that's really pronounced in provision 6. The rest of the code kind of goes to our responsibility to the public and to society. And this brings in the idea of policy change and of social justice and reducing disparities, which may or may not be completely relevant in this particular scenario unless we find out that this is perhaps a pattern of care. And so our public health nurses who may be watching this can really resonate with the idea of using policy as a way of improving health settings.
Great. Thank you for that wonderful application of the Code of Ethics, in practice, everyday practice. And you touched a little bit on the resources. So our next polling question asks our audience, what resources or who, if anyone, Nancy should have called on to help her in this situation? There are a number of choices for our audience to choose from, including patient, your nurse colleagues, and your nursing director. So please select your choice and submit your answer. And what are you seeing?
I think our audience gets it. There's a wide array of choices here of who to bring into this problem-solving team. And starting with the patient, perhaps.
Yes, we have less selecting the patient and the family, but we have to remember they're an important part of our team. In this case, we don't know much about the patient's preference or the family involved in the care, but patient-centered care dictates that we involve patients. They're the center of our care. The Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual patients' preferences, needs, and values. We need to make sure that we hear what our patient has to say. And especially for our pediatric patients, family is so important. They're part of the care. Every morning when we round, we should be wondering and asking them, what is it that's most important to you? Do you know what the plan of care is? Do you know when you're going to be discharged? Is there anything we can help you understand? That's our ethical duty to the patient. I think the next one is nurse managers. You can see that so many of you selected nurse managers. It's so important. We do not function in healthcare as a one individual show. It's everyone involved, and they're there because of the same reason. They care. They're there for the patient. We need to make sure that we work as a team. So if there is an issue and you're going chain of command, up the chain of command, and you're not able to reach your medical colleagues, I think it's important to realize that there is a nurse manager that you can page as a page away or a call away. There's charge nurses on the floor and additional resource teams. And even your colleague next to you, you can find out they might be more experienced and could give you ideas about what next steps you should take. So I think there are a lot of individuals that we can reach out to, and it's important to remember that.
True, and going back to the patient for a minute, it's probably likely that Mr. Van has known for a very long time that he has one kidney. And he is probably equally concerned right now about the fact that he hasn't had any urine output for a very long time, coinciding with this persistent pain he has in his back. So involving the patient in this scenario would be an exemplar of patient-centeredness. as you mentioned, the Institute of Medicine talks about this. They point out that the patient is actually the source of control. It's a very strong phrase. The patient is the source of control about his or her care. So good point. Um, and we do have a variety of responses on the rest of our list of resources here that, for instance, the nurse, once the immediate problem is handled, could be thinking of some resources like team steps is one if there is a communication issue where team steps is this idea that anyone at any time can bring up an issue and nurses have a duty to do that. And that may be something that the nurse pulling her team together or his team together wants to introduce into this practice setting. Or working on the idea of promoting just culture in the practice setting. But I want to sort of focus on the fact that professional nursing organizations can also be a very big help in resolving situations like this, especially when there's a pattern of care like this going on.
I think it's an important point when you mention work environments and just culture. Working in a hospital where they support just culture, I had an experience where I was at the bedside, I had an antibiotic due for the patient, and something didn't feel right, but I went through the process, did the barcoding, matched the label to the medication, and ended up paying the medicine. But after half an hour, realized the bag is not half complete. I checked, and it was the wrong label on the bag. I felt awful. It was really a terrible moment for me. But I reported, I went through the event reporting system. And in a week, I received the most surprising email, and I hadn't realized that people are tracking this in the background. And the pharmacist, someone from the pharmacy, had emailed me to thank me for reporting the error. And it just felt really the right thing to do, and it felt really good to be recognized for doing the right thing. So I think it's important when leadership supports efforts and are part of the team solution.
Right. Just culture, which is something that was promoted from the aviation industry actually a while ago, that kind of goes to the idea that we don't want to just know about the mistakes that couldn't be covered up, right? We want to know about how to prevent mistakes, and we do that by encouraging an environment of prevention and not punishment. So it's very important and helpful. It goes to the idea of justice, and it's not fair to just blame people.
So this brings us to our final polling question. Have you ever been in a situation where you were kept from doing the right thing for your patient and still wonder, did I do all that I could have? So we'd like to hear from you. What kinds of situations have you experienced?
Wow, that's we have a huge, what is that, 80% saying they have been in a situation like that. Uh, it's a very, like I said, an endemic issue that we have. In fact, I remember in the worst case scenario, the impact of lingering moral distress on nurses can actually lead to their own lives coming to an end. The very publicized story of Kimberly Hyatt, who gave an overdose to a pediatric patient. You mentioned pediatrics earlier, and was immediately treated as a criminal by her practice setting, by her facility. She was put on administrative leave. She was walked out of the building, and she was made to feel like this was singularly her fault, and she ultimately committed suicide. There's actually a concept called the second victim that addresses this, that when a terrible adverse event happens, we think about the patient as a victim, but we also have caregivers and healthcare providers who can be the second victim.
I think it's so true. I could see it resonates with a lot of you, and it resonates with me. I've been in situations, especially when I started in nursing, where I wasn't sure what the next steps were, what I needed to do.
I think having awareness first and finding resources and being educated and knowledgeable about situations, ethical situations that come up, you'll become stronger and empowered to have a voice to speak out. I know when I started getting involved, I really wanted to know the right conversation to be effective in my communication with my team when I said, there is a concern. We need to approach the patient again, talk about this issue again. But I needed to be empowered to do that. So I found my voice being involved in professional organizations and reaching out to the ethics committee, attending meetings and conferences. I know through the research of Dr. Pavlich, who's at UCLA, and I've been involved in her research as a subject, so I've been following her research. She's demonstrated that when nurses don't speak up and don't speak out and don't find a resolution in the problem, they carry that burden with them for years. There's regret that just add up. There was a nurse at a conference who got up and said, this case has haunted me for years. And it shouldn't be that way because eventually what happens, nurses have burnout, they have compassion fatigue, and they either leave the profession or have a lot of other physical issues or emotional and mental issues that come up. I think we need to do a better job of taking care of each other and having discussions like this.
And it's very empowering that the code encourages that as well. It does say, I'll repeat, that we have a duty to take care of ourselves.
And we have to be compassionate towards our patients, families, and others that we interact with.
Great information. Now we have an opportunity to take some questions from our audience. So the first question is for you, Eileen. You've talked about the Code of Ethics, the provisions in the Code of Ethics for nurses, and one has us paying attention to our health, our commitment to ourselves, as well as the commitment to the patient. So let's say in this case study that Nancy has finished her shift and she's now been at the hospital for 14 hours. She recognizes the commitment both to her own health and taking care of herself, but also that of the patient. In that situation, what should she do?
I think that that's, first of all, a common situation, Terry. And secondly, I think we have a two-pronged approach to that. The first is the primary obligation to the patient. Patients cannot be abandoned. So there is that short-term duty to take care of the patient. But then there is the longer-term solution to this problem. We can't rely on nurses working endless amounts of overtime, long shifts. There needs to be change in that practice setting so that nurses can have the time to take care of themselves so that they can deliver better care. So Nancy should first take care of the patient, and secondly, she needs to address the situation in her setting so this doesn't keep happening.
Great. We have another question from our audience, and Anna, it has to do with empowerment. You have spoken about empowerment a couple of times in our dialogue today. So what are some strategies to help nurses become empowered so that they can practice inside an ethical environment following the Code of Nursing?
Thank you for that question. I think it's important to realize that we can't know it all, just the same as clinical information. When we start as a new nurse, there's just so much to learn. But the first thing I learned as a new nurse was my resources. Who could I go to ask questions, or where can I look up the policy and procedure? I think feeling that awareness first, that you need to have a voice, you need to speak out. But for that to happen, you need to have the knowledge and skill necessary to do that. So for nurses to feel empowered, I feel like they should get involved in things. Get involved on your ethics committee. How many of you know that you have an ethics committee in the hospital? A lot of the unit practice councils now, the governance, shared governance, they have ethics committees as part of their unit practice councils. So get involved and follow mentors and people who really know ethics and can guide you in that practice.
You know, speaking of that, I knew a nurse who in her hospital started a moral distress committee.
That's really cool.
She felt that maybe nurses didn't have the access they wanted to the ethics committee, So she started a moral distress committee, and it was open not just to nurses, but housekeepers could come, other people who were observing what was going on in practice settings. So again, that collective power that we have.
Thank you. Another situation that nurses are commonly finding themselves in is brought to us by our audience. And this is a situation where you have to discharge a patient because we know patients are staying for shorter lengths of time in hospitals, but yet the nurse hasn't felt like they've had enough time to educate the patient or the care provider. So how do you resolve that situation? What's the best course of action?
It reminds me about nurses saying we discharge people thicker and quicker these days.
Absolutely.
Going back to what we've been talking about earlier today, I think first of all, naming the situation. What kind of a problem do we have here? Is this an ethical dilemma, or is this again a moral distress situation? And if it's a moral distress situation where the nurse knows what the right action is to take to do proper discharge teaching, but is being kept from doing so, the next question is what information is needed and how do we remove these external constraints? So that may involve pulling other people into the situation, pulling other staff into the situation so that there's the time that's needed to do proper discharge teaching. And this is in the facility's interest as well, because we know that hospitals are being penalized now for folks coming back to the hospital in a rapid fire manner, so within 30 days of discharge. So good discharge teaching diminishes that likelihood of happening, of the rapid rehospitalization happening. So a nurse who goes to her administration and says, listen, you have to figure out a way that we can have the time to do proper discharge teaching is actually serving the patient's needs and the facility's needs.
Great, thank you. Another question coming from our audience has to do with the family interest. And I think we're all familiar with this situation when the family issues are in opposition to what's in the best interest of the patient. So Anna, I'm going to start with you if you would reflect on that question, and then perhaps Cheryl, if you could give us some insight as well, that'd be terrific.
I think it's important when that does come up, when patients and the team don't agree with the plan of care for the patient, it's important to have communication, and often. We set up, when I worked in ICU, we set up weekly family meetings to update the patients, the family, even if the patient didn't have a voice, they were unconscious or they were intubated. And we tried to understand where the family is coming from. We would clarify their goals for the patient and their plan of care. And if we needed to, we involved ethics as soon as possible, because sometimes having multiple perspectives is helpful. And when ethics gets involved, I think they offer us a different perspective. So it is a challenging situation, but I think having communication and team meetings, family meetings often is one of the best solutions. And I would just add, because I think, Anna, you did an outstanding job of responding to that, it really is bringing in the facilitator, someone who can help to bring that family to some kind of resolution about how to move forward. And I will say that if the patient is able to articulate their interest, then our primary responsibility is to the patient.
We have some questions coming in about the case study. So Eileen, a number of our viewers are interested in Nancy's moral distress. And I'm wondering if you could comment a little bit on the notion that perhaps this was negligence on her case. What do you think?
Well, we do need to have all the factors present in order to determine if there's negligence. And that does include what harm was caused and the direct causal link between the behavior of the nurse and whatever harm may have resulted. We don't know from this case what harm resulted. It may have been, maybe in the next hour there was a medical response and everything turned out okay. But without knowing that, we really can't say this is a case of negligence. Again, we don't know what's going to happen with Mr. Van or what may have happened with Mr. Van. We just know that this is a situation where there could be some negligence if the right actions aren't taken.
And I think I would just like to add, thinking back of the issues, it could be system issues. Maybe Nancy didn't feel supported or she ran out of time to page the physician. We're not sure why she did not go up the chain of command and follow through. But I think looking from her perspective, if I was in her shoes, and I've been in her shoes different times, I've gone home wondering what happened to the patient and did I cause any harm. So I think it's that inner struggle and regret of not doing more is where the moral distress comes from.
And the fact that this comes close to even suggesting a true case of negligence, as our audience picked up on, really does give Nancy and her colleagues, like the shift that she reported off to with this situation, it really gives them some ammunition to go up the food chain, as we say, or to her managers and administrators and say, this was a risky situation. And just because there was no permanent harm doesn't mean we shouldn't address it.
We have another question coming in, and this has to do with a story that you related earlier, Anna, in the case of having to break bad news to your patients. So what are the ethical considerations that nurses should think about when they have to share some bad news with a patient? Thank you for the question. I think it's important to come from a place of compassion and care, like our Code of Ethics Provision 1 says. But I think honesty is very important. We have limitations in medicine and in nursing. We can't just promise the world to patients. Working in a situation like in an academic center, people think we're Mecca. They come there to be healed and to be saved. I think being honest up front of what we can provide them and what we can do is really important. So our duty is to be honest to the patient and family, and I know sometimes there's resistance there. And then do the best we can. We have to provide evidence-based practice, research-supported practice, and include the team and use all the knowledge we've gained through this exercise today.
That's right. I talk to my students all the time about this. It can be uncomfortable for the nurse to be the bearer of bad news. But again, the patient is the source of control, and we do honor autonomy and veracity. And so it is our duty to give patients the information they need. It also calls on us not to do false reassurance or to avoid bringing up a subject because it makes us uncomfortable. We need to go to where the patient is and be in that uncomfortable situation with them as they explore what this means.
And one way we can do this, we can work together as teams, like a buddy system. I think back when I was a new grad, I did not yet have my strong voice of what I needed to say. I would ask my resource nurse, my manager, please come in with me. Can we set up a time to do this together? And it's a very complicated issue, then it should really be done as a team. We have multidisciplinary rounds to discuss issues like this. Most places do. And it's important to bring up the concerns from that bedside and do it as a team. The next question I'm sure each of you will have comments on. And Cheryl, I'll start with you. What advice do you all have for nurses who feel like they're not being supported by administration in these situations?
Yeah, that is a really tough situation. And I think this is where I would encourage you to gather your facts, do that small R research, and know what is the information that you need to take to your administrators and your managers. And then you have to do the best you can to make your case. I would encourage you to bring your colleagues along and make sure that you have really gathered all of the evidence that you can have to support what is the point of view you want to give. You may find that when you speak out, then things will become uncomfortable if, in fact, your manager is not able to listen. And there are risks when you choose to take other action, which could be moving outside of that facility. Maybe using media, maybe doing some informational bulleting in your area. So there are risks to those kinds of behaviors. But again, what we're trying to do is be fully present and ethical in our actions.
I would just like to comment that data is so important. Just going in and saying, I've experienced this, and coming from an emotional place, people like stories, but unless you have data to back it up, people don't trust you or follow through with change. The next step, I think, so build your case, build data, and then build coalitions. It's so important. If you have concerns, your other colleagues have concerns as well. If the manager is not being supportive, get your unit to form a team, a formal team maybe, to talk about the issues and come up solutions together. I took it to the next step of being involved in professional organizations and bringing my issues to my local group and finding solutions, brainstorming ideas and finding solutions with others. So I think it's important to feel empowered to take it to the next step.
And I would add to the power of data, the right kind of data. So nurses, even direct care bedside nurses, need to be able to talk money. It really helps when you're trying to persuade someone, you need to know what information is going to be persuadable. Just as with the scenario where we were talking about discharge teaching and the importance of that to preventing hospitals from being penalized by patients having to come back in because they got inadequate discharge teaching. Talk the money. That's very often where nursing's power in saving money and in achieving triple aim can be achieved.
Looking at this question from the other point of view, how do we hold our profession accountable to the code of ethics? Cheryl?
Wow, that's a really good question. I think we principally will do that by being good peer reviewers with each other. That we are talking to each other, that we are collaborating on how we're going to problem solve. And I think we have an obligation as a profession to hold ourselves accountable individually and as a collective.
I would agree.
Yes, I think nurses should be talking about the code and what's in it. They would be surprised if they it's a very skinny book with a lot of power in it. If they took the time to read it, I think they would feel very affirmed about what's in it and talking about it. And I also think if each nurse takes it on his or herself to be an exemplar, then they set an example of where other nurses really want to be.
Well, our hour is flying by, so if each of you could just, in a very short statement, summarize the most important strategy you would like our audience to walk away with today from our dialogue, please share that with us. And Eileen, I'm going to start with you to summarize the most important strategies you'd like our audience to walk away with.
Thanks, Terry. Just like with the 5 whys that go to root cause analysis in just culture, I think nurses should think about the 5 whats when they're dealing with scenarios like this. So first, what's the problem? Define that desired state and the current state. Secondly, what information is needed? And we have talked about that a lot today. And how do you get it? The third is, what are the choices of action that you have once you have the other 2 pieces in place? And then what action will be taken and who will take it? And finally, just like with reassessing as part of the nursing process, what's next? So I think if nurses ask themselves those 5 questions, they will make some progress on that.
Thank you. Anna? I think ethical conflict cannot be prevented. We're going to be facing dilemmas and situations constantly, especially with the changing healthcare, with newer technologies. I think finding nursing's voice, strong voice, is important. So being educated, finding resources, and knowing your moral reasoning, where you stand, being aware of your surroundings is going to be very helpful. So I would encourage you to get involved, sign the petition, go to conferences that are about ethics locally to you, and get involved in your unit practice councils and professional committees. And I
think my takeaway is know the code. It is your guide. It's not a cookbook, it's not a recipe, but it is your guide. It is a way to think about these issues and to give you the language that you need to be able to talk about it and think about it and process it. So keep it with you and use it as an authoritative statement to help give you support.
Thank you all. Cheryl, you started us off earlier in our hour talking about the pledge. So could you remind our audience and tell us a little bit more about the pledge?
Yes, thank you, Terry. So remember, this webinar is about action. So take the pledge on making ethics a part of everyday nursing practice. You will receive a link to the pledge in the email that will come to you following the webinar. If not, you can also find it at the Johns Hopkins website, the School of Nursing, along with nursingworld.org, ANA's website.
Thank you. Thank you, Anna, Eileen, Cheryl, for sharing your wisdom and your knowledge with us today. Nurses make ethical decisions every day and help patients do the same. Through your case study, you've illustrated how the Code of Ethics for Nurses remains relevant and shapes contemporary nursing practice. A few last-minute reminders for our audience. We do have another case study that is available on the webinar console if you'd like to download it and hold your own conversation. And if you're looking for continuing education credit from our conversation today, you will need to complete the evaluation survey, and you'll see the link on